Hello students, so now we're going to talk about care for clients with skin problems. Next slide. Alright, so we're going to talk about erosis, which is dryness is the other fancy name for it. It's a very common problem among especially older people. What you see is fine scaling of the scrotum, the skin, generalized pruritus, and scratching may result to secondary infections such as impetigo because especially if they have long nails. So you should be thinking about what are some of your intervention for someone who has this condition that continuously itch. Next slide. There are some collaborative management in this case. It includes try to hydrate the skin. Either by providing fluid, providing moisture to the skin, and maybe some antihistamine can be used to help with the itching. So bathing and moisturizing soap, oil, lotion definitely will reduce the dryness. Water softens the outer skin layers, but cream is what seals it in. So, water and then cream. Next slide. Pruritus is itching. It is caused by the stimulation of the itch specific nerve fiber at the dermal epidermal junction, right? So it is subjective. So if someone says I itch, it's just like pain, I itch. What you have is this, the itch, scratch, itch cycle, constantly, goes on. So it needs to be, addressed. Cool sleeping environments is usually helpful. The fingernails again should be trimmed, short so that if they do itch, it doesn't impair the skin and therefore causing secondary infection. Antihistamine and topical steroids, and those are, you could start off with a lower concentration over the counter to see if that would help alleviate the itch. Next slide. Sunburn, we talked about the different types of burns. So this is a first degree superficial burn. So, refer back to your burn section. But cool bath, soothing lotion, antibiotic, and again, trying to make sure that we don't have any secondary infection and steroids to help with the pain. Next slide. Hives. Hives is it's a presence of white or red edematous papule or plaque of varying sizes, and usually from some type of allergic reactions or drugs and so forth. So antihistamine may be helpful. We want to avoid overexertion, alcohol consumption in warm environment, which generally will worsen the symptoms. But with hives, you want to stop the reason why they're having hives, right? Next slide. The phases of wound healing was discussed in our burn lecture, so just follow that. But there are three phases: the inflammatory, fibroblastic, and then maturation and remodeling phase. Next slide. Hi, I want to spend time with ulcer because definitely this is an issue that we experience, and especially long-term care facility and individuals who are not able to do certain things. So pressure ulcer, what you see here is the tissue's damage, and it's usually caused when the skin and the underlying soft tissue are compressed, right? And compressed between a bony prominence, so bony prominence, the heel, right? The coccyx area, the elbow, the back of the head, to an external surface for an extended period of time. It happens, by different forces, so pressure, and then you have friction and you have a shear. So a friction, is a mechanical force that is exerted when the skin is dragged across a coarse surface, such as in this case your bed linen. So you have two forces that are moving across one another. So that's what friction is, right? And it's usually pressure is not involved with friction, right? Whereas with shear, there is friction plus there's a force of gravity that's pulling down, like pulling down from the back of the head, right? So it's important to make sure that we avoid that. Next slide. So this is just a picture, a really nice picture that is showing you the differences between friction and shear. And as a nurse, there's definitely ways for us to prevent some of this. I also want you to pay attention to the differences between a pressure ulcer, right, a decubitus ulcer versus an ulcer, a stasis ulcer. So with the decubitus ulcer, we said usually there's some type of pressure, right? There's some type of pressure, and what happens is the shearing, the friction, all that is going to decrease circulation, right? When it decreases circulation, it's going to lead to tissue hypoxia, ischemia, necrosis. The tissue will sludge off and then will lead to an open wound, and then there's different level of that. Whereas with stasis ulcer, the underlying issue is poor circulation, but the poor circulation will lead to poor decrease in blood flow. So similar to the decubitus ulcer, in turn, when there's decrease in blood flow, you see the same effect: tissue hypoxia, ischemia, tissue necrosis, the sludging off of tissue, and then of course also an open wound. So different pathophysiology, but similar outcomes, right? So with stasis ulcer, you could have it because of venous insufficiency, right? The venous system that is not as efficient, right? Or stasis, stagnation. So there are differences, with the stasis ulcer. What you usually see is edema, itching, that is usually increased when someone is standing. And if you look at the skin, it's shiny and brown, right? Shiny and brown. Shiny and brown. And generally, how to treat it, the treatment, will be different, right? The treatment will be different. So one, we said the issue is pressure, so we're trying to relieve the pressure. The other is circulation is a problem. So our focus is to increase the circulation. Next slide. So there are some people that have high risk for decubitus ulcer, pressure ulcer, individuals that have mental status changes, individuals that are not able to get up and move, individuals that have nutritional problem, individuals that are incontinent. Okay? Yeah, individuals that are incontinent. Whereas with the stasis ulcer, people at risk will be individuals, hypertensive, smokers, people that have venous or arterial diseases will have this different, will be at risk for venous stasis ulcer. Next slide. All right, so what we want to do is just try to relieve the pressure, right? Because the focus in this lecture is really decubitus ulcer, but it's to relieve the ulcer. So how are we going to do that? So we want to make sure that we provide adequate relief to prevent it. So turning the patient, and taking them off of the bony prominences. They have capillary occlusion pressure, which tries to collapse the vessels to rest it, or pressure relieving product and devices. They have beds that air, cradling, elevating, this kind of stuff, and positioning your patient to try to get the pressure off of their bony prominences so that it doesn't lead to the different stages. All right, next slide. All right, so for the wound assessment, the pressure ulcer and their features are classified and assessed in 4 stages. Stage 1, 2, 3, and 4. And this is really, really important. A stage 1 wound is a sore that is not open usually, and it's usually red, and patient will complain there's some pain. The temperature will be, increased a little warmer. In a dark person, a dark skinned person, it's kind of hard to see. So usually the area is a little darker. It looks different from their general body. Whereas a stage 2 ulcer, the skin is there's a break in the skin, there's a sore. It's usually painful, and usually the sore would extend to a deeper layer. right? It doesn't blanch. I'm sorry, it looks like a scrape, right? It looks like a scrape, all right? It looks like a scrape. Versus the stage 3 on ulcer that extend into the tissue beneath the skin, right? It form like a small crater, you know, and usually there's no muscle or tendon or bone involvement. Versus the stage 4, which actually involves the muscles and the bone. Stage 3 and 4 usually there's little or no pain, right? Little or no pain. Next slide. This is a really awesome image that is showing you the different stages. So stage 1, remember I told you about the redness. Stage 2, it's a deeper layer, but not as deep as the stage 3 or stage 4. Right? Next slide. So when you are assessing the wound, it's really important. Usually most facilities have like a wound nurse. So they usually look at, assess and identify the location where it is. It's in the coccyx, the left heel, the size of it. So it has to be measured, the color of it. Is it necrotic? Is it black? Is it red? Does it have fatty tissue in it? The extent of involvement. Is it down to the muscle? The depth of it? The cell type in the wound and margins. Is there exudate? What's the condition of the surrounding skin? Any foreign bodies in it? So those are all will be part of your assessment. Next slide. So a wound that is exposed, remember this, a wound that's exposed is always contaminated, but not always infected. And that's what we're trying to prevent, infection, right? Contamination is the presence of some organism without any manifestation, right? The wound infection is contaminated when there's pathogen to the degree that growth and spread cannot be controlled by the body's immune system. Okay, next slide. All right, so now we are talking about the management of the wound, and one thing you have to understand is that generally there are 4 types of wound management, right, or debridement. One is called autolytic, that's AUTOLYTIC, enzymatic, ENZYMATIC, mechanical, or surgical, right? So those are the different ways that we can debride. The first one, autolytic, usually uses the body's own process, enzyme, to break down, the eschar tissue. And it's usually done through using a semi-occlusive dressing. You've heard of transparent dressing, hydrogels type of dressing. All right. It does have some advantage and disadvantage. Some of the advantages of using autolytic dressing would be that there's no damage to the surrounding skin, right? It is only selective to the area that is necrotic. The process is safer, because it uses the body's natural process to rid the wound of its necrotic tissue. It is easy to perform, very effective, and not painful for the patient at all. The disadvantage is that it takes time, right? It takes time to see the results, and the wound can be routinely monitored. It may be difficult because it's covered, right? The next debridement was, was enzymatic debridement, and this is, what happens is chemical agents are used to break down the necrotic tissue enzymes, right? They're very good if there's a large area of necrotic or eschar formation. So the advantages, it works faster, than the autolytic, and if you apply it properly, there's little risk to the healthy tissue around it. But the disadvantage is that the patient may have the chemical agent prescribed, and it may be expensive. Care, must be taken to make sure that the healthy tissue does not come in contact with the chemical agent. And generally, a secondary dressing may be required to absorb the exudate. And then, of course, you have the mechanical debridement, and this is one of the oldest form of debridement. It uses moist to wet dressing. So we use dressing. This is the nurse is going to do that, or the wound nurse is going to do that. Then manually remove. It causes non-selective debridement of the necrotic tissue and the sludge. Hydrotherapy. Sometimes the patient soaked in a whirlpool can also be considered, a form of mechanical debridement. The advantages are, it's cost effective, right? Due to the fact that the gauze is the material that is used. The dressing change are simple, so the patient can be taught to change them on their own. Disadvantages, when you remove the dressing, it may remove, the healthy ones as well. And it's time consuming, for it, because it has to be changed, and the patient must spend a lot of time in the whirlpool to achieve the effect. All right, next slide. So some non-surgical therapy would be physical therapy, drug therapy, nutritional. There are some techniques that are used to try to increase, the circulation, the blood flow to the area using electrical stimulation, hyperbaric oxygen, topical growth factor, or skin substitute. Next slide. So this is what a hyperbaric chamber does. It would help increase the oxygen flow to the area. Next slide. And we talked about surgical debridement. Here is, surgically could cause pain, so making sure that the patient is, is pre-medicated or graft for the area that is wounded. Next slide. So now we're talking about bacterial infection, folliculitis, furuncle, cellulitis. These are all bacterial infection. Folliculitis is the superficial infection involving only the upper portion of the follicle, like the hair follicle. Furuncle is a boil, which is much deeper into the follicle. And cellulitis, generalized infection by Staphylococcus or strep that involves the deeper tissue. So clearly, cellulitis is a lot more serious condition, and all of them must be treated with antibiotic. Definitely cellulitis. Next slide. So this is a furuncle, so boil. Next slide. Cellulitis, see how much is red, and it can cause a lot of damage, so we have to treat it with antibiotic. Next slide. So here we're talking about herpes syphilis. Herpes type 1 is the most common, and it's classic recurring cold sore. Now it's usually in the mouth, but it could be in any different parts, right? Because even type 2 can be found orally because of different sexual practices that people have. Type 2 is herpes syphilis number 2, and it's usually genitalia. And then you have herpes zoster also. Next slide. You have some client, they call it hepatic Whitlow. It's a form of herpes syphilis infection that occurs on the fingertips of the medical personnel who have come in contact with the viral secretion. So, it is transmitted, and so we want to make sure that we're protecting ourselves using standard precaution. Next slide. So let's talk about herpes zoster shingles. Again, it's caused by a reactivation of the dermal varicella zoster virus. So individuals who had chickenpox previously are the ones who are at risk to having herpes zoster. So what you see is multiple lesions along that occurs in the segmental distribution in the area where the nerve was infected. So the eruption can last several weeks, several weeks, and usually there's a complication of that is referred to as post-hepatic neuralgia. If zoster itself has pain in the lesion, but usually it goes away, but sometimes it doesn't go away, and then this complication of post-hepatic neuralgia occurs. So it's a painful condition that affects the nerves and the skin, can last 3 months or even longer. It's very sensitive to touch. Even the clothing that the patient wear It can be debilitating, because of the discomfort. The treatment for this is anticonvulsant therapy that is used to help, like Neurontin can be used to help with the neuropathy, with the neuralgia pain. All right, next slide. For all of the all right, so this slide we're talking about the fungal infection. You've heard of many fungal infection, candiditis. You've heard of tinea pedis, tinea menis, caries, capitis, corporis. So you've heard of the different type of tinea, different type of fungal infection, and the type of infection is where it is. So the feet, the body, those kind of things, right? The yeast. Next slide. So it's really important for you to get the history of when things start, the assessment findings, what does it look like. Tinea, ringworm is an example of that, and the circular shape of it, so the description of it. So what they do is they do some lab tests. The Taxix smear, that is trying to scrape the lesion, and usually you can help differentiate the different types of hepatic lesions. Is it a varicella? Is it a herpes zoster? Herpes type 1 and so forth. So you can differentiate what type of hepatic lesion it is by using that smear. The swab culturing the different areas and then see what it's in there. And then the potassium hydroxide, KOH. This test is very quick test and it's inexpensive, and it helps us to detect fungal infection. All right, fungal infection. Next slide. So intervention is, skin proper cleaning, isolation, not generally, but especially for the zoster, and the drug therapy that I use. Like I said, for zoster, you're going to use Neurontin. It's a fungal infection. Antifungal, diflucan can be used, and amphotericin can be used. So there's different drugs depending on how extensive the fungal infection is. Next slide. So bathing the area with antibacterial soap, removing any pustule or crust gently, applying warm compresses to the furuncle, the boils, because the warm compresses would help. Okay, so yeah, warm compresses would help, so that, applying Burrows solution, and solution is to try to dry off the lesions, avoid extensive moisture. And for the hepatic lesions, it's really important for those, the liquid, the vesicles, you do not want to pop it could cause blindness. And usually with type 1, with the herpes lesions, you could actually tell. The first episode is usually more painful. Recurrent episode, you'll see that, tingling sensation to the site prior to eruption. Antiviral drugs can be used, acyclovir, because it's a viral infection. It's not a bacteria, so you don't use antibiotic for it. You could put you can use antibiotic soap for the lesion that is ruptured, so that you prevent infection, but it is a viral infection. We can try to dry the lesions with the Burrows solution, and again, avoid contact. When there's active lesion, avoid sexual contact. You may even have, for the women, they may even have the lesions in their cervix that is not seen. That's one of the reasons why we'll do C-section generally when a woman has herpes. Next slide. So drug therapy, again, for the fungal infection, antifungal drugs, anti-inflammatory drugs can help with that as well. Next slide. Cutaneous anthrax. You might have heard about anthrax as a possible agent of bioterrorism. So this is the same anthrax we're talking about. This is cutaneous. It can, it's for the skin. It could be other issues of it. So it's caused by a spore of the bacterium Bacillus anthracis. Its diagnosis is based on the appearance of the lesions and culture, right? So If someone is diagnosed, they are treated with an oral antibiotic for 60 days. It's usually ciprofloxacin or doxycycline. Next slide. These are pictures of anthrax, the different lesions of it. Next slide. So now we're going to talk about lice. Lice, it could come in different form, pediculosis. It could be head lice, capitis, body lice, corypsis, pubic lice, right? So it's lice, but it's where it is. So the complaint that many customers, individuals complain about is pruritus, itching. There's the drugs, there are very different types of drugs that are available. Linden is one of them, Lindane, shampoo. So the key is with these type of lice, it's about the infestation is so great and it's highly contagious. So laundering of the clothing and the bed linen and treating everyone that is involved. Next slide. And usually, okay, next slide. Scabies is another condition. It's very contagious skin disorder caused by the mites. It's transmitted by close contact or infected bedding. All the female mites are the ones that are, burrow themselves. It affects all people. Doesn't matter about money, age, and it spreads skin to skin. It is important for us to examine between the fingers because it tends to bear there, or the inner aspect, and elbows, the axilla, or the gluteal crease. That's where it buries itself. Excuse me. Infestation is confirmed by examination and scraping of the lesion under the microscope. Next slide. Common inflammation contact dermatitis. As the word says, contact dermatitis, you come in contact with something. So allergen, you may wear, some people are allergic to nickel, and so they put a necklace on, and then behind the necklace you see a reaction. So contact dermatitis. Soap. So it's important when someone has contact dermatitis, you are asking about any new product that you've used recently. They come in complaining of itching and redness. Any new product, right? Oh yes, I started using, Dove soap or whatever the situation is. So find out about what they did, something that was different previously. Atopic dermatitis. This is what we call eczema. It usually begins in childhood. There are eczematic lesions, is red and itchy, and usually accompany asthma. So eczema and asthma. We're talking more about this stuff in childhood, in the pediatric. So again, dry skin, itchy skin, thick, scaly, and it's really important because it itches so much that we have to make sure the kids have short nails, because they can itch and scratch, and when they scratch, it's going to lead to other problems that we should be mindful of. And that other problem is something called impetigo. That's an infection. It's an infection, staphylococcus infection, and you see like blisters in the face, the neck, the diaper area. Highly infectious, right? So staphylococcus, streptococcus can cause it. And so highly infectious, so we want to make sure that we treat with antibiotic to get rid of that. And usually you have to treat for at least 24 hours before they're not as contagious anymore. Next slide. Oh, interventions include steroids, avoidance of oil-based product, antihistamine for the itch, moist. They need moisture, and pretty much bathing them with while they're in the shower, you keep their skin moist and apply the lotion. Contact dermatitis, you want to stop the contact with whatever it is that you have. Steroid always works better for eczema, but one of the things we need to be concerned about is because these usually starts in childhood. Steroids also thin the skin. Next slide. All right, cirrhosis. Cirrhosis is a lifelong disorder with exacerbation and remission, scaling disorder with underlying dermal inflammatory response, and they've linked it to autoimmune. There's different forms of it, but nonetheless, the disease process is the same. Next slide. So it's a picture of it. I mean, look at that. What do you say to that? You know, body image disturbance. Lots of taking care of and treating this client with dignity and not bias. Next slide. So treatment is steroids, you know, tar preparations, other topical therapies, ultraviolet light. There's systemic therapy because it's autoimmune, like cytotoxic agents, immunosuppressive agent like Imuron, and lots of emotional support. Next slide. All right, so tumors. Benign tumors are benign. It means that they may not kill you unless if tumors, the benign, but they are pressing on a vital organ. In this case, we're talking about the skin, so they would not. But there may be, you know, problems associated with it, such as body image disturbance, like the tumor to the right here that you're seeing. So cysts, seborrheic keratosis, keloids, and moles are referred to as benign tumor. So if it doesn't bother the patient, then we can leave them there. Next slide. But we are concerned when it is tumor that is malignant, right? So these are skin cancer, and melanomas are the ones that are highly metastasized, and severe survival depends on early diagnosis and treatment, and that is very similar to any type of cancer. Exposure to sunlight in the early years of their lives before 40 usually are the skin cancers that you see in later adult life. Next slide. So this picture is showing you it's showing you the lesions, you know, and one thing about the indication that a lesion is cancerous is there's an acronym ABCDE. So acronym A means asymmetry, right? So is it round, like consistently round, or is there some asymmetrical shape? So it's not equal around. So based on what you're looking at right now, all right? Are the borders regular? They should be regular, not irregular. So borders are irregular. That tells you skin cancer. Color variation, so multiple colors, like the ones you're seeing here, you can see there are multiple colors. So yes, that tells you skin cancer. And how big it is also tell you high probability of cancer, and that if it's larger than 5 millimeter. And the E is it evolving? You know, a mole that is not cancerous doesn't change in shape. A mole that is not cancerous doesn't change in shape, right? It doesn't change its shape, it stays the same. But if it evolves over time, then that may be an indication that we should be concerned about. Next slide. So in terms of management, you know, you could scrape it, you could, you know, cut it, you can dry it, you know, and of course, you know, if it gets to the point where they may need more invasive cancer, then, you know, we want to do more drug. You know, making sure they teaching them to examine their skin, their own skin, and annually by a physician, so that we can identify, especially if someone is alone and they cannot see. Generally, you don't see your back, you don't see behind you. So if you use a mirror, get other family members to be involved in the process, and definitely see your doctor frequently. Next slide. So if not removal, then they can do drug therapy or radiation to the side. Next slide. Acne, you know, is a red pustular eruption affecting the sebaceous glands of the skin, right? So puberty, they have more of those fatty oils. Progressive, that is manifested, right? So generally, there are treatment, birth control. The teenagers would tend to help with it. Antibiotic would help with it. A drug that is usually used is Accutane. Accutane can help with the condition, but we need to make sure that these individuals use a backup method for pregnancy because of the teratogenic effect to the unborn child. All right, but hand washing, not constantly playing with the lesion, can help in that regard. Next slide.